dim the lights. Note. Is that better? Okay, no sleeping. Okay, so we're going to start with cardiology, just because it's everywhere on the exam. So it's a good topic to be comfortable with. Here's your patient. He comes in with chest pain. What do you want to do? Best first test. That's how a lot of these questions are written. Best first test, best initial treatment, best next step. Let's do an EKG first. So we'll do an EKG. That is your best first test for a patient with chest pain. And what are you looking for on that EKG? ST changes. So we're going to look for ST elevation. Is that the only criteria to diagnose a STEMI? What else is a scary EKG change if it's new? A new left bundle branch block is also scary. So our criteria for a positive EKG are 2 millimeters of ST elevation. Hey, what's up? Or a new left bundle branch block. And if you don't remember what that looks like from your EKG course, that's kind of a wide, flattened QRS. Either of those fulfill criteria for a STEMI. So the ST elevation occurs pretty much immediately. And remember, there are some later changes in the EKG after an MI. T-wave inversion happens a little bit later. And then the Q waves, those are our markers of an old infarct. They last pretty much forever. So also remember, this is prone to come up probably in 1 or 2 questions on your shelf, where in the EKG you're looking for these different types of infarcts. So particularly remember 2-3 and AVF. If you see 2-3 and AVF either described in a question stem or on an EKG printout, that tells you that the right coronary artery was infarcted, and it correlates with an inferior infarct. The rest of those, probably a little less likely to show up. Memorize them if you have the brain space, but definitely 2-3 and AVF, remember that that's inferior, and that's the right coronary artery. So treatment of a STEMI, we're going to want to restore blood flow, right? That's the problem. So we want to restore blood flow. And the cath lab is the best. Thrombolytics, when can we give thrombolytics? What's the window where thrombolytics are allowable? The book I read said 6. So thrombolytics, if you catch them within 6 hours, or if you can't get them to a facility where they have a cath lab, within a reasonable amount of time, then you can give thrombolytics. Oh, hey, friends. So the contraindications for thrombolytic therapy might also show up on your exam. So some contraindications to thrombolytics. Anybody? Yeah, so if you're bleeding, right, thrombolytics is not a good choice. When else? Sure. So if they're anticoagulated, you'd be a little bit more cautious. Ever a hemorrhagic stroke. So ever in the past, if they had a hemorrhagic stroke, you can't give thrombolytics. If they had a recent ischemic stroke, you can't give thrombolytics. And then recent closed head trauma. So if they're, fell off a horse and then had a heart attack, no thrombolytics for them, not allowed. So, also something that comes up in the Q banks, I don't remember it on my test, but I got like a million questions on it in the Q banks that I did. This case of a right ventricular infarction. So the symptom complex is different than a regular garden variety MI, which is I think why they like to ask about it. And it's a patient who has hypotension and tachycardia, so they're kind of shocky. They do have JVD, but their lungs are clear, so they don't have the crackly, cardiac pulmonary edema, and they also don't have pulsus paradoxus. So it's a kind of a confusing clinical picture unless you're looking for it. So kind of in a nutshell, if you see somebody that looks like they're in shock, they've got JVD, but their lungs are clear, think about a right ventricular infarction. And this is important because the treatment is drastically different between this type of MI and the garden variety type. You don't give nitro, and why is that? If your right ventricle has failed, why is nitro a bad idea? Ooh, I hear whispers. So basically it's because these patients are having a problem with preload, right? Their right ventricle can't pump, They can't get the blood to the lungs and then to the right side of the heart. So really the best treatment here is fluids. They need preload to be added. And nitro is a vasodilator or venodilator, so it's going to further decrease the preload and actually worsen their shock-like picture. So don't know if it'll be on your shelf, but it was in enough of the question banks and review books, I figured it was worth a mention. So let's say we did our EKG and there was no ST elevation. What's the next test we want to do for our patient with chest pain? Chest x-ray will probably be done if you're in the ER, right? They like to do those. But if our patient still has chest pain, the EKG was normal, are we totally reassured? What should we do to make sure there's not something cardiac going on? Yeah, now let's do our biomarkers. So cardiac enzymes is the next test. So if you're given a clinical scenario, the EKG's already been done, it's normal. Now we want to order our cardiac enzymes. And if the first set is normal, are we done? Go home? Hit the happy hour? No. Yeah, so we need at least 3 sets, right? Q8 is typically how it's done at most hospitals. And why is that? Why do we check more than 1 set? This is back to step 1. Yeah, so most of them won't all be increased if you catch it early enough. So they have different rates of rise depending on the different cardiac enzymes. So we check every 6 to 8 hours to detect a trend. And what I'll point out here is myoglobin. It's the one that rises first. It also drops off first. So if you get a question with a patient who had an MI and they're in the hospital, you're watching them, what's the most sensitive marker for a repeat infarction, a second heart attack? You'll want to look at the myoglobin because CKMB and troponin can both still be elevated from the first heart attack. So a second infarction can be picked up by myoglobin because it's the first to go up and it's the first to go down. You wouldn't expect it to still be elevated a couple days later. Okay, so we treat these NSTEMIs with morphine, oxygen, nitrates, aspirin or clopidogrel, and a beta blocker. That's kind of your classic cocktail for a cardiac patient. And coronary angiography is the best test to schedule for these patients. You want to get this test ordered within 48 hours because that's really how we determine how to proceed from there. So coronary angiography tells us whether or not we need to do some kind of intervention. And what are our options for intervention? Stent or CABG, right? So stent or bypass. And stent is really the standard of treatment unless your patient has certain factors that make CABG the preferred option. And you need to know those. When do you do CABG instead of a PCI? So if you've got left main disease or 3-vessel disease, unless you're a diabetic, and then the threshold is lower. 2-vessel disease in a diabetic, or 3-vessel disease or left main. Yes. So, or if there's greater than 70% occlusion, or if they're just really sick. So you've given them maximum medical treatment, but they're still really symptomatic, still having pain, or after an infarction a few days later, they've got terrible angina where you're suspicious of a reinfarction. Those are all reasons for CABG instead of stenting. So we always send these folks home on aspirin or clopidogrel if they've got a stent. They always need a beta blocker. You need an ACE inhibitor, particularly if they've got some type of left ventricular dysfunction, and we need to give them a statin for prevention of future disease. And then nitrates for their chest pain. Okay, so what if our cardiac enzymes were negative? What are we calling our patient with chest pain? A faker. So pessimistic for so early in your medical career. So let's assume they're not faking, because they rarely are on the shelf exams. You rarely have a faker of a patient on your shelf exams. Real life, maybe. Shelf exam, no. So they've got chest pain. It's terrible. It's crushing. Substernal radiates to their left arm. It's unstable angina. Any new angina is unstable, right? Even if it's just with exertion, if it's new, it's unstable. So the workup for unstable angina, you'll want to schedule an exercise EKG for these folks. And they may ask you what types of medicines you should discontinue before an exercise stress test. Beta blockers and calcium channel blockers would be the answer there. There are some reasons you can't do an EKG stress test, and they like to ask about these. If they've got an old left bundle on their EKG, it makes it very difficult to interpret. If they've got that wide, weird QRS complex, it can make it difficult to assess for any ST changes during exercise. So So that would be an indication to do an echo instead of an EKG. Also, if they're on digoxin, that makes interpreting the results of a stress test unreliable, so an echo would be indicated there also. There are a lot of patients, you've probably noticed, that can't perform exercise necessary for an exercise stress test, and in those patients, we chemically stress them. So dobutamine or adenosine are the chemicals we use there, and then MUGA, you may have seen this ordered or heard about it. So a nuclear medicine test that can show the actual perfusion to the heart, so you can see very clearly if there's any area of blockage that's leading to ischemia. So what does a positive test look like? It's if they have their chest pain, if they have their characteristic symptoms upon exercise, that's a positive test. If there's ST depression, it's a positive test. Or if their blood pressure drops, the test is also positive. So anytime you have a positive stress test, got to get them to the cath lab. And they need to get some coronary angiography. Okay, so after an MI, what do we worry about in our patients? The most common cause of death in a patient who had a heart attack. Arrhythmia, very good. VFib is the scariest one, right? So what if our post-MI patient has a new systolic murmur 5 to 7 days after their MI? It's a new systolic murmur. Regurg from papillary muscle rupture, absolutely. So the papillary muscles can become ischemic, weaken in the remodeling phase. Remember that from step 1? They can rupture, and that causes a regurg murmur. So it's a new systolic murmur you can hear. What if there's a murmur, but they also have acute hypotension, really sick, basically on death's door? What might have ruptured there? The free wall. So that's a ventricular free wall rupture. If you notice a step up in oxygen concentration between the right atrium and the right ventricle, that's septal rupture. Those are the buzzwords for a septal rupture. And it makes sense, right? If you have more oxygen in the right ventricle than in the right atrium, that means some of the oxygenated blood from the left side is scooting on over there to increase the oxygen content. If you see persistent ST elevation a month later with a systolic mitral regurg murmur, this one's kind of random. Not Dressler, I'm getting there. You're ahead of me. This is a ventricular wall aneurysm. Not sure why the persistent ST elevation. It may just be because of the thinner wall of the aneurysm inherently doesn't have the blood supply necessary, so you see the ST changes. And the MR murmur is because of the flow in and around the aneurysm outpocketing. So, Cannon A waves, they love to describe this on physical exam. Do you guys know what Cannon A waves are, what you look for? Where do you look for Cannon A waves? The jugular, right? You look at the JVP and you just see them bounding. They're Cannon, bounding Cannon A waves. And what do they tell you? Something's wrong with the heart. Well, I'm not to Dressler yet. Jumping the gun. So what would make blood bound back up to the neck? Sort of. It's a problem with the tricuspid. So what makes the Cannon A wave is when the valve between the atria and the ventricle is not opening in conjunction with the cardiac cycle. So, you're supposed to open the valve and blood goes through, but if there's AV dissociation, the valve isn't opening and closing properly, so blood, instead of going forward like it's supposed to, kind of rebounds back and gives the Cannon A waves that's visible in the JVP. So Cannon A waves, in general, means atrial ventricular dissociation, and in this case, it can be due to third-degree heart block if the AV node is ischemic. So, but in general, Cannon A waves mean the atria and the ventricles aren't communicating properly. There's AV dissociation. Now here we go, 5 to 10 weeks later, pleuritic chest pain and a low-grade temperature. Here's your Dressler syndrome. This is thought to be autoimmune, cause of pericarditis, and we treat this with aspirin on NSAIDs. Okay. So now I've got a young, healthy patient, and he's got chest pain. Now we do an EKG, because that's what we always do, right? Best first test for chest pain, and we see this. And I don't know if it's big enough, but can anybody tell me something characteristic about this EKG? Yes, diffuse ST elevation. Please know this EKG because you might see it. So what does diffuse ST elevation tell you? It tells you pericarditis. So other things they might tell you in the clinical vignette, the chest pain is worse with inspiration or pleuritic. It's better when they lean forward, so position affects the chest pain. And you might hear that rub that you might have heard on step 1, right, when you had to listen to the little murmurs. It was a friction rub. So this is pericarditis. And what do we do for it? NSAIDs, right? We just said that. So, okay, so some other causes of chest pain. If they tell you the pain is reproducible with palpation, think costochondriasis. If it's kind of vague chest pain and they had a viral infection a few weeks or a few months ago and they have a new murmur, myocarditis might be on the differential. If the pain occurs at rest, is worse at night, usually in a lady who also has migraines, think about Prinzmetal's angina. So this is characteristically worse early in the morning. And the test we use to diagnose this type of angina is an ergonovine stimulation test to characterize whether blood vessel spasming might be causing this angina. And calcium channel blockers and nitrates are the treatment of choice here. All right, EKG time. So this first one, anybody want to take a crack at it? What about the P waves? Winky Bach, yes. Did you guys see that YouTube video? Yeah. It's hilarious. If you haven't seen it, you should Google it. So the way they might describe this in a clinical vignette, it's progressive prolongation of the PR interval followed by a dropped beat. And that, as you guys correctly identified, is Winky Bach. Or Mobitz type 1. Mobitz type 1. Okay. So what about this second one? Third degree heart block. So what might you see on physical exam? Canon A waves. Yay. Good. Yeah. So this is third degree heart block. What they might tell you in the clinical vignette, they might tell you they found Canon A waves on physical exam. They also might describe it as a regular P to P interval and a regular R to R interval. But as we can see from the EKG, they're not associated with each other at all. There's not a P before every QRS spaced out regularly. So good. What about the second one, or the third one? Not AFib. Not AFib. With AFib, you typically can't see P waves. Good. This is MAT. So what they might tell you in the clinical vignette, if they don't give you this picture, they might describe it as varying PR intervals with 3 or more morphologically distinct P waves in the same lead. And this is good to know because it's bad news in terms of prognosis. This really happens in sick patients with bad pneumonia or otherwise really terrible respiratory disease. So if you see something and it looks kind of weird, you take a look at the P waves because if you can see them, it's probably not AFib. And if you find 3 that are different looking from each other, either inverted or a little sine wave or peaked and not peaked, if you see different P waves, think about MAT, multifocal atrial tachycardia. All right, top one here. What do you notice? Are the QRSs narrow or wide? They're wide, so that helps narrow down your possibilities. So it's wide. Is it fast or slow or regular? It's fast, so it's it's a tachycardia with wide QRS. So yes, it's VTach. So the description they might give you if they didn't show you the picture: 3 or more consecutive beats with a QRS less than 120 at a rate of greater than 120. So I led you astray. That's not a wide complex. And if we had counted the beats, that isn't greater than a block and a half. Sorry about that. I led you astray there. So this is not a wide complex. So it's just ventricular tachycardia. So, okay. So how do we treat VTach? It depends on how the patient looks, right? If the patient's unstable, hypotensive, unconscious, non-responsive, how do we treat them? Shock them, right? And then if they are stable, then we can use medical treatment. We can treat them with lidocaine or amiodarone. So it depends on how the patient looks. Are they stable or unstable? What is their blood pressure doing, etc. So the second strip there, I don't know if you can see it. It's kind of small. You notice anything about like this region right here? Yeah, can you convince yourself that that's a delta wave? Maybe it's not the best example I could have found on the internet via Google image, but that is supposed to be a delta wave. So then what does that mean this rhythm is? Yeah, it's WPW. It's Wolff Parkinson White. So they might describe it as a short PR interval followed by QRS greater than 120. So this is a wide QRS complex with slurred initial deflection representing early ventricular activation through that bundle of Kent. So super important. How do we treat WPW? The drug of choice was important on step 1. It's important for the medicine shelf. Procainamide, very good. Procainamide is the drug of choice for WPW. Even more importantly, what are you not going to give these patients? What medications are contraindicated in WPW? Anything that slows AV conduction. So beta blockers are contraindicated. Digoxin is contraindicated. The calcium channel blockers that affect the AV node, verapamil and diltiazem are contraindicated. Because remember, anytime we slow conduction through the AV node, that's just allowing more of a signal to go through that squirrely bundle of Kent and screwing it up even worse. So they might give you the picture. I think I got a question about like the medical student or the resident who went into the ER with palpitations, and they gave him a beta blocker, and then he sued the ER doctor 2 years later. You know, what did they give him that facilitated the lawsuit or something like that? So, or why? What was the basis? So remember the pathophysiology here, and that helps you remember what drugs you wouldn't want to give because it would worsen the arrhythmia instead of making it better. Okay, so what about the third one? That's flutter. See the sawtooth? So they might describe it as regular rhythm with a ventricular rate that's between 125 and 150. And the atrial rate, that's even higher, about twice that, 250 or 300. So that's 2 to 1 if we've got that distinction between ventricular and atrial rate. And how do we treat a flutter? Again, if the patient's unstable, it's easy, you shock them. Anytime they have an arrhythmia and they're unstable, you cardiovert. So that's easy. If they're medically stable, here's where beta blockers and digoxin have a role. So it's kind of similar treatment to rate control for atrial fibrillation. A-flutter and AFib are treated very similarly. Then that last one, would you like that to be your EKG? No. So what's that? Yes, that's torsades. So they might describe it as a prolonged QT interval leading to undulating rotation of the QRS complex around the baseline. And in the clinical vignette, look for some kind of electrolyte abnormality. Low potassium and low magnesium can predispose a patient to this. And then extending into the psych realm, a tricyclic overdose can also cause torsades. Okay, so what's this first one? Slow, fast, or normal? That's fast, so it's a tachycardia. Take a guess. Ectopic atrial. This is supraventricular tachycardia. This is SVT. So they might describe it. I think it's kind of hard to pick it out based on the EKG alone. The description makes it a little easier. If they told you it was regular rhythm and the rate was somewhere between 150 and 220, also the clinical symptoms help you here. This is like the 27, 28-year-old guy or girl who just suddenly has these terrible palpitations and then they suddenly go away. So there's a sudden onset and offset that's also pretty characteristic of SVT. Now, what's the first-line treatment for SVT? Very first thing you do for them when they walk in the door. Yes, carotid massage, good, because they're going to try to trip you up by giving you a bunch of drugs to choose from. But first-line treatment is actually non-pharmacologic. Carotid sinus massage. For the kids, we shove their face in ice water. I guess you could do that for adults too. Non-meds first, and then your medications. This is where adenosine comes into play. So with the tachycardias, adenosine might be the right answer if they're looking for a medication. So the second one here, there's kind of a lot going on. What I want you to look at is this business. What's that? That's a T wave. That's peaked. That's a peak T wave. So what does that make us think of? Hyperkalemia. Good. The medicine folks love hyperkalemia, don't they? So in the clinical vignette, they might tell you this is a renal patient who missed a bunch of dialysis appointments. Could be crush injury because the potassium is released from the damaged cells, burn victim, blah, blah, blah. The T waves are peaked, the QRS is wide, the QT interval is short, and the PR interval is long. So hopefully they give you peaked T waves. I had a couple questions on my QBank where they gave you those other EKG findings described, like the widened QRS and the short QT. So if you want to be safe, know them all. And I missed this one like 3 or 4 times on my QBank, this third one right here. WTF is that? Right? What do you notice about this EKG? So the baseline is kind of undulating, and that helps with the name. It's not MIT, because we don't really see morphologically distinct P waves. It's kind of hard to see them because it's such low voltage. So the 2 hallmarks here is there's alternate beat variation in direction, so it's kind of undulating, and then it's very low volume. So the clinical picture helps, right? You also notice pulsus paradoxus, hypotension, and distant heart sounds, and JVD. What does that picture make you think of? That's tamponade. So this is the EKG finding of tamponade. It's called electrical alternans. Electrical alternans. So it's kind of alternating. That's where the alternans comes from. And it makes sense if we've got tamponade, right? That blood is filling up the sac, so it's dampening the voltage. That's why it's so short, why it's such a low voltage EKG tracing. All right, number 4. There you go. You can't really see P waves there, right? There's kind of some squiggly business along the baseline. So this is AFib. They might describe it as an undulating baseline. Can't see the P waves. It's irregularly irregular. And the clinical vignette, the patient might be hyperthyroid. That's pretty common. Or somebody taking too much of their Synthroid. Might be some old dude with sudden palpitations, shortness of breath, or somebody with CHF who has valve disease, right? Because if your mitral valve is really bad, that leads to dilation of the left atria, which predisposes to atrial fibrillation. So rate control or rhythm control, which is better? Yeah, neither of them are better, so we do rate control, right? Rhythm control hasn't been proven to be any better than rate control, so we use drugs to control the rate of atrial fibrillation in our first line of treatment. So how do we do that? What meds? Beta blocker or DIG. Yeah, those are kind of the mainstays. Okay. So any questions about EKGs? I tried to pull out all the ones that I got questions on, either in real life or in QBank land. All right. So now let's go to murmurs, the other common question type in the cardiology section. So I've got a systolic murmur. It's crescendo, decrescendo. It's louder when they squat, softer when they valsalva, and you might see parvus et tardus in their pulses when you're palpating aortic pulse or peripheral pulse. Aortic stenosis, very good. So some things that might cause aortic stenosis. So old, right, calcific degeneration, I think is what it's called, of the valve. So it just could be old. Yeah, or if it's congenitally, the aortic valve is bicuspid, that might predispose someone to get it a little bit younger. More importantly, how do we treat it? Yeah, so do we shove a balloon in there and open up the stenotic valve, or do we just replace the whole enchilada? We replace it. So valve replacement is the standard of treatment. You only would do balloon valvuloplasty if you were just stabilizing the patient so you could get them to somewhere that could perform the operation. So, okay. So what about this second dude? It's also a systolic murmur, but it's louder with valsalva, softer with squatting, and hand grip. This might be a young patient in for their sports physical. Hypertrophic obstructive cardiomyopathy. So this is HOCM. The hallmarks to remember here is it'll typically be a younger patient. That'll help you, but also louder with valsalva, because the systolic ejection murmur of aortic stenosis is softer with valsalva, because valsalva decreases preload, right? So that makes less blood go across the stenosed valve. So that'll improve an aortic stenosis murmur, but it'll worsen a HOCM murmur. So that's kind of the differentiating factor that I remembered. Now where it becomes tricky is in this third fella, late systolic murmur with a click. And it's louder with Valsalva, just like HOCM, but softer with squatting. The key is the click. This also might be a younger patient. Yeah, so this is mitral valve prolapse, MVP. So this patient clinically might present with palpitations, some syncope, and then the murmur actually can be pretty loud. In our last systolic murmur, this one radiates to the axilla, and it's different from the other ones in that it's not an ejection murmur, it's holosystolic. Yes, MR. This is mitral regurgitation. Good. Okay, so another holosystolic murmur, but this is in kiddos. Most common congenital heart defect. VSD. Yeah, you thought there wouldn't be any peds on your test, but there might be. And then a continuous machine-like murmur. Remember this from step 1? PDA. Wide, fixed, and split S2. That's an ASD. Those are kind of just the key buzzwords. And then a rumbling diastolic murmur with an opening snap. If you did an echo, you might see left atrial enlargement, and it predisposes to AFib. Mitral stenosis, good. And blowing diastolic murmur with a widened pulse pressure. And this is the one with like the water hammer pulse, all those dead guys that have their, you know. I don't remember them anymore because I already took my steps, but you guys know. What's this one? Yeah, so this is aortic regurgitation. Mitral stenosis and aortic regurg are the two most important diastolic murmurs, at least in the adult population. So, okay. So really, when a patient comes in, they're not coming in, you're reading about them in the clinical vignette, they can have shortness of breath for cardiac or pulmonary reasons, right? So if you suspect a pulmonary embolus, that can cause shortness of breath, and that's a really scary cause of shortness of breath. You want to give heparin right away. Before you do your workup, heparin first is always the right answer if you really suspect a pulmonary embolus. You'll always want to check the O2 stat. If the pulse ox isn't given in the clinical vignette and the option to get one is there, that's usually a good idea. Anytime you suspect pneumonia, like if there are those characteristic breath sounds, egophony, all that business, you want to get a chest x-ray. Anytime somebody with congestive heart failure has a murmur, an echo is the right study to get, and compare it to an old echo to see if it's progressing. And for acute pulmonary edema, I got this question a lot in the Q banks. The trifecta of medications are nitrates, Lasix, and morphine. Any patient who kind of looks like they have CHF, but they're young, they're not our old person who we expect to have it, think about myocarditis. This is like the kind of random cardiac problem that mimics a lot of other things and has a confusing constellation of symptoms. So if they're young, if they had the flu a couple weeks ago, and they either have shortness of breath upon exertion or need 3 pillows at night, think about Coxsackie-B or some other viral form of myocarditis. And then also in a young patient, a cause of shortness of breath might be primary pulmonary hypertension. And this will cause cardiomegaly on a chest x-ray, and a right heart cath is the next study to order, because it can really definitively tell you whether it is primary pulmonary hypertension or congestive heart failure. And how is that? What pressure are you looking for on right heart cath? Good. See my high-tech drawing I made on paint? So this is your heart over here. These are your lungs. And if the problem is your heart, right, the problem is your heart, the congestive heart failure, your ventricle can't contract, you're not propelling blood forward, it's going to back up here, right, into the left atrium. And pulmonary capillary wedge pressure we use as a surrogate for left atrial pressure. So in CHF, this is going to be high. Whereas in your primary pulmonary hypertension, the problem is here. There's increased resistance in the pulmonary vessels, so the blood doesn't even get to the left atrium. It backs up into the pulmonary artery. So in CHF, we have high pulmonary capillary wedge pressure. In primary pulmonary hypertension, pulmonary capillary wedge pressure is normal. So that's really the key pressure to look at. They often give you a bunch of different pressures in these chambers and vessels. You really don't need them if that's the determination you're trying to make. All right. So if you did medicine at any of the sites that we do medicine at here, you've seen a lot of CHF and have seen how to manage it. So remember that it's divided into systolic and diastolic, depending on whether the problem is propelling blood forward or relaxing the heart in diastole. And the things that I saw questions asked about, are there reversible causes of either? So alcoholic dilated cardiomyopathy is reversible if they stop drinking, which they never do. And then hemochromatosis causes a restrictive cardiomyopathy, which is diastolic dysfunction, and that's also reversible with phlebotomy. So if you reduce the overall iron overload in the body, you can get some of your ejection fraction back, which is nice. So treatment of CHF, remember the medications that improve survival. Remember ACE inhibitors have been shown to improve survival, and beta blockers as well, for the same reason. They prevent remodeling in the ventricle. ACE inhibitors because they block aldosterone from remodeling, and beta blockers because they prevent epinephrine and norepinephrine from remodeling. Spironolactone, this is kind of newer. It's improved survival only if the heart failure is really bad, class 3 or 4. And then digoxin is usually the detractor answer. It does not improve survival, but it does help symptoms. So we give it to patients, it makes them feel better. They're less likely to be hospitalized with an exacerbation. All right, lungs. Got to know your chest x-rays. What do we see on this first one? Yeah, so this business right here, not normal. Oops, don't look at that. So here's a lobar consolidation. They might describe air bronchograms, which I always have a hard time seeing. This is pneumonia. The second one? Yeah, so what they might describe, the lung fields are really black, right? That's called hyperlucent, and the diaphragms are very flat. See a lot of air trapping. So that is COPD. And the third one? Yeah, so they describe it, the heart is big, greater than half of the AP diameter. There's curly D lines and kind of fluffy interstitial edema. That's CHF. The fourth one? Yuck. What's that? Cavity containing an air fluid level. Does that help? That's an abscess. That's an abscess. Caused by what kind of bug? Staph can, and also anaerobics like to cause abscesses. And then my last picture. Kind of hard to see. Yeah, good. It is TB. They might describe upper lobe cavitation, consolidation, and they may show hilar adenopathy. That's tuberculosis. And then the last one, I couldn't find a picture, but the description in the question stem says that there's a thickened peritracheal stripe and splayed carina bifurcation. So the carina is, instead of being nice like this, it's kind of splayed upward. Not sarcoid. Think of some crap that would spread the carina. Instead of being nice, it's all splayed open. What would get in the way to esophageal rupture? No. Oops. Okay, I guess I'll have to tell you. So 2 things. Right? Think of where the left atrium is in the context of the heart, right? It's in the back. So if the left atrium is enlarged, that can start to push on the carina and cause it to splay. So really bad mitral stenosis can cause this chest x-ray finding. The other thing, which I'm more interested in these days, is cancer. Mediastinal lymphadenopathy can also get in the way of the carina and splay it open. So cancer, really bulky mediastinal disease can do it, and also, which is probably more likely to be on your test, left atrial enlargement from mitral stenosis. All right, pleural effusions. So remember, if you see more than a centimeter on your lateral decubitus x-ray, you tap it so you can see it. And please, please, please know the difference between transidative and exudative effusions. So if it's transidative, remember the causes are more likely systemic. They're big picture diseases. CHF, nephrotic syndrome, or cirrhosis can cause transidative. Some other random buzzwords, if it's transidative and also has low glucose. Did you say it? Oh, complicated more is a term I've heard to describe exudative. I was thinking of rheumatoid arthritis. Because in RA, there's lots of white blood cells, right? It's an autoimmune disease. There's lots of white blood cells around, lots of inflammation. Those white blood cells eat up glucose just like bacteria. So if you're thinking low glucose and exudative, that's a bug. If you're thinking low glucose and transudative, that's RA. High lymphocytes in a transudative effusion, that's tuberculosis. And if it's bloody, yeah, bad news. Either PE, and sometimes cancer-related pleural effusions can be transudative. So if it's exudative, the most common causes, cancer can also cause this type of effusion, and pneumonia is more common. A parapneumonic effusion is more likely to be exudative. And then complicated means either you see bugs, it's gram stain positive, it's really acidic, the pH is less than 7.2, or there's low glucose because the bugs are eating it. So for anything that's complicated, we got to drain it with a chest tube. And then the Lights criteria for transudative, have y'all been pimped on that to oblivion? What are Lights criteria? Good. So if LDH is low in and of itself, under 200, if the LDH effusion to serum ratio is less than 0.6, and the protein effusion to serum ratio is less than 0.5, it's transudative. All three of them have to be present for it to be transudative. If any one of these is violated, it's exudative. Okay, so pulmonary embolism, we talked about this a little bit already. Remember that the risk factors for this, surgery, any post-op patient is at risk for PE, long car ride, cancer, or nephrotic syndrome both give a hypercoagulable state. And remember the symptoms. They've got the pleuritic chest pain. They might be spitting up blood. Tachypnea is probably the most common symptom. They might have a decreased pulse ox, and they're probably going to be tachycardic. So random signs, they might show you something like this on chest x-ray. It's a little wedge infarct. It's got an eponym, doesn't it? Is that a Westerfield? Westermark. Yeah, Westermark. So, but it's a wedge infarct from the pulmonary vessel being blocked by the clot. Remember, anytime you suspect it, you got to give them heparin even before you do your diagnostic workup. And VQ scan or spiral CT are both acceptable options. I don't think they'd have you choose between them. But do remember that pulmonary angiography is the gold standard. It's just a very morbid procedure, so we don't like to do it. And remember, for anticoagulation, you treat with heparin right away, and then you give a warfarin bridge. So you can use thrombolytics if it's a really severe clot, but remember the contraindications for thrombolytics we talked about earlier. And then you do surgical thrombectomy if the clot is immediately life-threatening. The IVC filter, you may have seen some patients with these placed. I had a couple at the VA. These are when they are at high risk for a hypercoagulable state, but they have contraindications to chronic anticoagulation. Like they fall all the time, they drink 80 beers a day. We don't want to give them warfarin or heparin, so we might place an IVC filter. Okay, so ARDS. So you see the characteristic chest x-ray at the corner of a slide. It's kind of the bilateral, fluffy infiltrates. And I wrote a little bit about the pathophysiology. The causes are more important for you guys. Sepsis is the big one. A lipopolysaccharide from gram-negative sepsis is a big cause of ARDS. Also aspiration, trauma, or pancreatitis, also important for the medicine shelf. So 3 diagnostic criteria for ARDS. Have you been pimped on this to oblivion? It's not a pulse ox. There is a characteristic or a criteria that deals with the amount of oxygen, but it's not pulse ox. It's PaO2 over FiO2. So they take the PaO2 from the ABG divided by the fraction of inspired O2 from, their venti mask or whatever. If that ratio is less than 200, it's ARDS. The second criteria is a radiographic criteria, the x-ray that I showed you. And the third one is pulmonary capillary wedge pressure less than 18. So what is this one about? This is ruling out cardiac causes of pulmonary edema. So this third criteria proves that the pulmonary edema is from the problem with oxygenation and not with a problem of forward blood flow. And how do we treat it? Oxygen with pressure. Yes, we need PEEP. We need positive pressure ventilation. So, and if you guys memorized all those vent settings and all that business, you've done better than me. I just remember PEEP because we use it for ARDS. Okay, so as far as pulmonary function tests, I know that they do a pretty good job in the noon lectures teaching you guys about this, so I'll really only hit the highlights here. As far as obstructive versus restrictive, look at the FEV1 to FVC ratio. That's really where the money is. If that ratio is decreased, if the FEV1 is disproportionately decreased compared to the FVC, we're dealing with an obstructive process. And if the ratio is normal, both the FEV1 and FVC are decreased to an equal extent, then we're probably dealing with restrictive disease. The other thing that I often forget is bronchodilator response. They might ask you what constitutes a positive bronchodilator response, and that magic number is 12%. So if the FEV1 improves greater than 12% with albuterol or a bronchodilator, then you've diagnosed asthma. COPD and emphysema, their ratios, their lung volumes don't improve with a bronchodilator. And then the diffusion of carbon monoxide can also help you determine what type of obstructive process or what type of restrictive process you have going on. The diffusion is reduced in emphysema because you've got all that fibrosis, actually you have more space because of the destruction of the alveoli. It's also reduced in interstitial lung disease because of the fibrosis. It's harder for the oxygen molecules to get across. Okay, so know your COPD. How do we diagnose an acute exacerbation? What are we asking them about? Someone just coughed. We ask them about their coughing, right? Their sputum. So if they have a productive cough for longer than 3 months and over 2 consecutive years, that's COPD. The exacerbation criteria I'll get to in a minute. How do we treat COPD? We treat an exacerbation with steroids for sure. Just our outpatient dude with COPD, first line, we'll give them ipratropium or the newer tiotropium. Beta agonist is second line, and then third line, if they're really bad, theophylline. We don't like to use theophylline because it's got a pretty narrow therapeutic window and can cause arrhythmias. So when do we start O2? Yes, so if their pulse ox is less than 88, or if you do a blood gas and it's less than 55. If they have right heart failure, cor pulmonale, they raise the threshold a little bit and start O2 sooner. Here's what I was trying to get to. Criteria for exacerbation. This is when their sputum changes. So any change in sputum, amount, color, whatever. Their sputum is changing. It's probably an exacerbation. And how do we treat it? Antibiotics and steroids. So usually it's a macrolide and steroids. And then NEBS and oxygen. Best prognostic indicator. I got this question wrong maybe 2 or 3 times before I finally learned it. It's the best. So if a COPD patient says, Doc, how long do I have to live? How bad is my COPD? Very good. FEV1. So we do spirometry. FEV1 is the best indicator of prognosis. And what's been shown to improve mortality for COPD? 2 things. Yeah, oxygen for a long time, greater than 18 hours a day, I think sounds right to me. And then if they smoke, they gotta quit smoking. So those are the 2 things that have been shown to help. And then an important question, why is our goal for pulse ox 94 to 95% instead of 100? Absolutely, yeah. So these folks are chronic CO2 retainers, so their little respiration sensor doesn't really work in terms of pH or CO2. So they really need hypoxia to drive their respirations. And important vaccinations in the outpatient clinic for our COPDers? Pneumovax. Very good. Pneumovax. All right, so our COPD patient says, check out my hands. This just happened 6 weeks ago. What is up? You guys are so good. Yeah, that's cancer. You need a chest x-ray. So this physical finding is called hypertrophic osteoarthropathy. It's really acute onset of clubbing, and it means cancer. It means lung cancer. So if they ask you for the next best test, it's not pulse ox, it's not spirometry, it's chest x-ray. All right. So for asthma, If your patient tells you they have symptoms twice a week, but their PFTs are normal, how bad is their asthma? What type of asthma do they have? Mild intermittent. And so they get albuterol only for treatment, just a rescue inhaler. They don't need any kind of daily treatment. If the patient has symptoms 4 times a week, they cough at night a couple times a month, but their PFTs are still normal, the next one. All right, so what do we treat the next one with? I'll give you that. Yes, so now we add inhaled corticosteroids. If the patient has daily symptoms, a night cough more often, twice a week, and now their FEV1 is starting to go in the crapper, 60 to 80% predicted value. So the treatment we add is a long-acting beta agonist, which is what I heard. So what are the names for these again? So we have mild intermittent, moderate. So there are 2 flavors of moderate from what I remember. I'm stalling because I actually forgot. I think it's moderate intermittent and moderate consistent. Someone have a book? Anyone want to check me? Someone look it up and get back to me when you get there. The last one is severe. So from what I remember, there's 1 flavor of mild, 1 flavor of severe, and 2 flavors of moderate. When it's severe, it's when your FEV1 really tanks. It's less than 60%. And the symptoms are pretty much consistent. So what do we add to our treatment regimen here? What do we add? We can add an oral steroid or like the leukotriene modifying agents. So everything that we had our moderate patients on plus the leukotriene modifying agents and possibly oral steroids if it's really bad. So remember during an exacerbation, if they give you a vignette where the patient is in the ER, well, first of all, what would you expect their PCO2 to be if they're in the middle of an asthma attack? High or low? You expect it to be low, right? They're wheezing, they can't breathe, they're tachypnic, they're going to be blowing off a lot of CO2. So their PCO2 should be low. What happens, as in what I've described here, when it starts creeping up to normal, maybe a little high? Exactly. Their intercostal muscles, their diaphragm, they're getting tired, and they're not able to compensate for the inflammation in their airways by breathing faster. So actually a normalizing PCO2 is a bad sign. You've got to have a low threshold for that and a low threshold for intubation. And then a complication, this is more in kiddos. There's a complication of asthma, allergic bronchopulmonary aspergillus. There's a special antibody we look for in the blood for this, probably lower yield. Okay, so that's the obstructive diseases. Let's talk about some restrictive lung disease. If they describe 1 centimeter nodules in the upper lobes with eggshell calcifications is the big buzzword there. It's so silly. Silicosis. So that's silicosis. And the thing to remember here is they are they're more predisposed to tuberculosis. I think about it in that it makes sense. They're both in the upper lobes of the lung. TB likes to live in those little silicosis nodules. I'm not really sure if that's true, but it is true that people with silicosis are more predisposed to it. So they need a tuberculosis test annually. If the vignette describes reticular nodular markings in the lower lobes and pleural plaques, that's asbestosis. And they are at higher risk for bronchogenic carcinoma and mesothelioma. So if the lesion is a patchy lower lobe infiltrate, you can culture some thermophilic actinomyces. What does that friend do for work? Farmer's lung. So they shovel hay or something. So hypersensitivity pneumonitis is more commonly known as farmer's lung. And thermophilic actinomyces is the bug to remember there. So if you see hilar lymphadenopathy, increased ACE levels, erythema nodosum. The patient might be a young female African American. Sarcoid. So that's sarcoidosis. So some harder questions. They have hypercalcemia. Por qué? What? Vitamin D. So they have high vitamin D levels. And why do they have high vitamin D levels? So it's my understanding it's the macrophages. So the macrophages in the granulomas produce a vitamin D-like substance. And that increase in the vitamin D-like substance is what causes the hypercalcemia. So that's my understanding of why the blood calcium levels are high. An important specialist doctor to refer these folks to? Hem-onc, maybe. I was thinking ophtho. They've got a 25% chance of uveitis that can lead to blindness. So if they haven't been evaluated by ophthalmology, that's an important referral. And then for diagnosis, really the only way you can definitively diagnose it is by biopsy, biopsying the non-caseating granuloma, and the treatment is steroids. So you found a pulmonary nodule. What do you do first? Look for an old foam. Yes, good. So the first step, you got to find an old chest x-ray to compare, because really you're going to be a lot more concerned if it is increasing in size or if it's brand new. So out of these little Goombas, which one is scarier? This little dude or this guy? This guy is scarier. Why is he scarier? It's bigger. What does he not have? What are some characteristics of a benign nodule? What would make you reassured? What? What? So the buzzwords you might hear are popcorn calcification. Spiculated is actually usually a scarier sign. If it's got the spicules and the little burr spurs, that's usually the calcification pattern of granuloma. It's got, of cancer. If it's popcorn calcification, it's more likely a hamartoma. That is the most common benign pulmonary nodule. Concentric calcifications make you think a granuloma used to live there, like an old TB infection. And also if they're young, if it's small, if it's well circumscribed, those are all characteristics of something benign. Scary characteristics are if it's got that eccentric or spiculated calcification, if they're old, if they've been smoking 80 pack years or whatever, that's bad. And so we need to be a little bit more aggressive in the workup. So we need to biopsy the lesion, and depending on where it is in the lung, that'll determine how we get to it, either by bronchoscopy, if it's central, or open thoracotomy, peripherally. So it kind of depends on where the lesion is. Okay, so here are your scary cancer symptoms. Weight loss, cough, dyspnea, hemoptysis, where they keep having pneumonia in the same lobe, their lung keeps collapsing. Those symptoms all equal cancer, right? That is lung cancer. So for the different types of cancers, there are 4 that you need to know, and there are different buzzwords they can give you to suggest which one they're trying to talk about. So the most common cancer in non-smoking patients, adeno, and it can occur in the scars of old pneumonia. That was something I learned. Where do these cancers usually arise? Are they central or peripheral? They're peripheral, and where do they metastasize? Kind of some random places. Well, some of them aren't so random. Liver and bone, those are pretty standard places of metastasis. These also like to go to the brain and adrenals. So adenocarcinoma is one of the peripheral cancers, and it metastasizes to the liver, bone, brain, and adrenal glands. Adenocarcinoma also gives a characteristic pleural effusion. Exudative or transudative, do you think? Exudative, and it's got high hyaluronidase. If you're looking for it, probably a little bit less high yields, but there you go. So what if we've got a patient who's got all our scary lung cancer symptoms? They also have kidney stones, constipation, they feel like crap, they've got low PTH, and their lung mass is centrally located. Very good. So that's the paraneoplastic syndrome for squamous cell that you need to remember, hypercalcemia. And that's because they've got the parathyroid hormone-related peptide. So what about our patient? Shoulder pain, ptosis, got a myotic pupil, and facial edema. The Pancoast tumor, or in the superior sulcus tumor. So this is superior sulcus syndrome, also Pancoast tumor, and it comes from small cell carcinoma. Small cell is also central. So you could usually remember it, squamous and small cell, they start with S, they're both central tumors. So we got another patient with ptosis, but it's better after looking up for a minute. Good, Lambert-Eaton's. So better with continued upward gaze is how you tell it from myasthenia. Lambert-Eaton syndrome is also associated with small cell, and it's because we have those antibodies to the presynaptic calcium channel blockers that I told you about first year. Remember those? Comes full circle. Okay. So old smoker presents with low sodium, but their mucous membranes are moist and they don't have JBD. SIADH from? Small cell. Very good. And then chest x-ray showing some peripheral cavitation and a CT showing pretty widely disseminated metastasis. What's the cancer we haven't talked about yet? Large cell. So the things you need to remember about large cell, it's another peripheral cancer. It's more likely to cause cavitation, and they're usually pretty metastatic upon diagnosis. So really, for treatment, we care about small cell and non-small cell. And what's the difference? Yeah, so the non-small cell tumors, it's usually a little bit easier to resect. Small cell tumors are really sensitive to chemo and radiation. So those are the mainstays of treatment first line. All right, I only have a few slides on gastroenterology, mainly concentrating on inflammatory bowel disease. So between Crohn's disease and that other one, UC, thanks. Which one involves the terminal ileum? Crohn's, good. And remember, the symptoms can mimic appendicitis, and because it involves the ileum, they can have iron deficiency anemia. Continuous and involving the rectum, UC or Crohn's? That's UC. Who has an increased risk for primary sclerosing cholangitis? UC. Who's more likely to have fistulae? Crohn's. And anytime you see a fistula, metronidazole is the drug of choice. Who has granulomas? Crohn's. Who has transmural inflammation? Crohn's. Who's cured by colectomy? UC. Who has a lower risk if they smoke? UC. UC. So smoking increases the risk for Crohn's, decreases the risk for UC. And which one gives you a higher risk of colon cancer? UC. That's another reason they can be cured by colectomy, and it can prevent the colon cancer that they have an increased risk for. And then which one is associated with P-ANCA? UC. Good. Okay. So treatment, ASA, sulfasalazine, can maintain remission. Corticosteroids is given during a flare to induce remission. And as I said, metronidazole for any ulcer or abscess in a patient with Crohn's. So some pictures you might see. This is an abdominal x-ray. I don't know if you can see that. The arrows are trying to point to some badness in the wall of the colon. This is toxic megacolon. This is pneumocystis intestinalis, air in the wall of the colon. Hard to appreciate on this chest x-ray, but you can see it's widely dilated, right? This looks bad. So this is toxic megacolon, a surgical emergency. What about this barium study? That's string signs. So what is this, UC or Crohn's? Crohn's, more likely in Crohn's. What's this badness? Pyoderma gangrenosum. Should we give antibiotics for this? Looks like a horrible bacterial abscess, right? So we give antibiotics, right? No. You treat the underlying UC, and this will get better. Don't IND it. Don't give antibiotics. It's not an infection. This is just granulation tissue and white blood cells. And then these little guys, they're on the anterior tibia. They're painful. Erythema nodosum. So these were also in our sarcoid patient, and they're also present in patients with UC. All right, so LFT buzzwords. What would give you an AST bigger than your ALT and a high GGT? It's what you're doing after the shelf, right? You're drinking. Alcoholic hepatitis. What if your ALT is greater than your AST and they're both in the thousands? Thinking about a virus. If your AST and ALT are both in the thousands, but you just had major surgery, cardiac surgery, or you were just in a horrible car accident. Shock liver. Yes, so that's ischemic hepatitis. Shock liver can be confused with viral hepatitis, but you don't have that characteristic ALT greater than AST. What do you think of when your D-billy is elevated? Obstruction. Yeah, I think it's something wrong with the biliary tract, gallbladder, something of that nature. There are also some randoms, right? Dubins, Johnsons, and Roeder from USMLE Step 1. So what about elevated indirect bilirubin? Gilbert, very good. And Kriegler-Najjar, right? Those are the two randoms. What's more common? Hemolysis. So hemolysis is more common. The two randoms are Gilbert's and Kriegler-Najjar syndrome. So, okay. So what if on your LFTs you see elevated ALK phos and elevated GGT? That's obstruction, right? The ALK phos is pretty nonspecific, but the GGT tells you the problems with the ducts. And what if the ALK phos is elevated, GGT is normal, and calcium is also normal? Pregnancy. So what if you're an old man? What? Yes, Paget's disease. Very good. So it also might be an old dude who has to buy a bigger hat because his skull is getting thicker. Hearing loss is also common because the little ossicles get all screwed up because of the disease. So good, Paget's disease. What if the anti-mitochondrial antibody is positive? PBC, also more common in ulcerative colitis. What if the anti-smooth muscle antibody is positive? That's autoimmune hepatitis. The difference here, you can treat autoimmune hepatitis with steroids, but it really doesn't help PBC. So that's an important treatment difference. So what if you see high iron, low ferritin, and low iron binding capacity, and a screwed up liver? That's hemochromatosis. They also might be diabetic and have that kind of golden skin color. And as we kind of hinted to earlier, we treat this with phlebotomy, getting rid of some of the iron that's overloaded. And what if the ceruloplasmin is low and the urinary copper excretion is high? Yes, Wilson's. So these patients have hepatitis. They might also have some psychiatric symptoms, mainly because the copper likes to deposit in the basal ganglia. And then you can see those common Kaiser-Fleischer rings in the cornea. All right. Most common bugs causing meningitis. Name me some.